I have a unique medical practice. I get to specialize and work with complicated patients that haven't gotten better despite working with many other doctors or practitioners. And the patients I see have been misdiagnosed or were simply suffering from things that most doctors we just weren't trained on. So today, let's fix that. I'm going to teach you how to approach the most missed and misunderstood cause of chronic disease in my patients, and that's mold. So here is what I want to do. We're going to review the two main types of clinical presentations mold can cause. We are going to review the problems with the Shoemaker approach to diagnosing mold toxicity. And then at the end, I'll show you what I think is the best way to make a diagnosis of mold toxicity in your patients. The first thing that just has to be said is that mold can cause both an allergy syndrome and a toxicity syndrome, and they are distinct entities, and we want to make sure that we are not confusing them or grouping them all into one category. And so we'll see here that when mold illness first came on the scene, this was the first publication I could come across was in 1983. The World Health Organization gathered enough information that they wanted to say, here is this clinical entity that we're seeing. And they described it as patients suffering from symptoms of illness without apparent reason, right? And the symptoms would increase in severity the longer they spent in the building and improve over time or even disappear when they were away from the building. And initially, the first crack at it, they were saying, look, we're seeing a lot of allergic symptoms. We're seeing dry, itchy eyes and sneezing and runny nose or congestion, headache, maybe low-grade fatigue. And I think this first idea, the first crack at this, really left in clinicians' minds the idea that mold is just allergies. It's just kind of this allergic syndrome. And while mold certainly does cause allergies, it also causes toxicity. So I'm going to come back to this, but I wrote this in a way to try to show that there's both distinct clinical entities of the allergy, there's distinct from toxicity, but there is overlap. So you have a patient who comes in and they primarily are suffering from the allergic components of mold, which are documented again and again in the clinical literature. There is no debate whatsoever. It is absolutely 100% certain that mold will drive allergic syndromes of all sorts. So that's where we might see predominantly, these generally allergic symptoms. But at the same time, there is also no doubt for those who've actually read clinical literature that there is a very different type of clinical syndrome that we see. We're seeing psychosis, we're seeing depersonalization, autoimmunity, tics, seizures, tremors, neuropathy, POTS. These are not allergy symptoms. It's very different, right? And so what we don't want to say is, just mold is just allergy and dismiss these other symptoms. And we simply at the same time don't want to say everyone has mold toxicity, right? And neglect the allergy. We want to say, okay, look, there is a clinical spectrum. On this spectrum, people can have some, both, or no symptoms when they're exposed to mold. And in the middle, I just wanted to highlight some of the symptoms I see common to both allergy and toxicity. So let's take a look at what a real severe allergy picture can look like. Here is a young man whose exposure to mold really led to a profound dysregulation of allergic responses. And this poor guy was eating only 5 foods. His parents were needing to give him EpiPens on a weekly, even semi-weekly basis, just to keep him breathing from the amount of food reactions he was having. And he was just struggling, despite all the medications the allergist could give him. He's doing wonderfully right now. We got him through this. But this is what we're thinking of when we're thinking how severe mold can really drive eczema, atopic diseases. And so again, clinical literature, again, I'm not making this up. We got meta-analyses here, right? Undisputed that mold can cause asthma attacks in asthmatic children. But not only can it cause, right, drive asthma attacks in a patient who already has asthma, we know that simply living in a moldy environment can cause the development of asthma in the first place, right? So this is a cause of asthma, is exposure to mold. So we increase the risk of developing asthma, new diagnoses of asthma in kids by 53%, right? That's a big risk. That's a big risk factor. And this is one of the pieces of evidence why mold is a cause of disease. So much of this presentation is going to be on the toxicity, but I just couldn't start a presentation without minimizing how devastating allergy can be. Don't minimize symptoms of mold when there are allergies in your patients. The brain fog, the depression, the itching, the fatigue, the sleep disruption, this can be really, really severe. And at its worst, you'll see this present as chronic idiopathic urticaria, CIU. And this is mold until proven otherwise 100% in my clinic. And so we really want to lean into the treatments that we were trained for allergy. Maybe that can be a lecture for another day, but we don't want to minimize the allergic component here. So distinct from allergy, we have toxicity. And this gets into some of those symptoms that we described before that are not allergic. A long quote, but let's lean into this because this came from my clinic and it was just so classic from the story that I hear again and again and again and again. So this gentleman, my arms and my legs stopped working for 20 hours the first time. And then 1 week later, the same thing for 8 to 10 hours. I went to the hospital and I was diagnosed with conversion disorder, right? Don't worry, friend, it's in your head. I had a headache that lasted for weeks. I was very weak for 6 to 8 months, right? Later, we found out that home had toxic mold after my wife started having heart symptoms. Prior to this, we're active and rarely sick. You'll hear that a lot. I was fine before I moved into that home with the mold, right? Since I have struggled with a lot of coordination issues, weight loss, weird anger issues where I didn't struggle before, right? That's not allergy, mood swing, severe depression. This is very common with exposure to mold. The mood dysregulation is a very big piece of mold. And I really want to highlight that here. I talked to my doctor a year ago. He said, mold is an allergy. It's just an allergy. I don't think that's causing your problems. I've been trying different things. I'm getting stuck. My fight or flight has really been off. And over the past few years, spinal tap, MRIs, blood work, blood panels, nothing shows up. My numbers are good, right? So this is where I think the majority of patients who are being made sick from mold in a toxic place get to. And this is what you are going to be able to fix if you actually watch the entire video, right? Okay, let's get into some of the scientific basis for why I can feel so confident that mold toxicity exists, because I still hear, mold toxicity doesn't exist, it's only allergy. Okay. Here's a wonderful publication in 2003 from Dr. Vojdani and Dr. Andrew Campbell. So what we see here is a case control, and we are looking at control patients not being exposed to mold, and we are seeing patients with mold exposure. And what you very clearly see are symptoms here, right, that have nothing to do with allergy, right? Memory disturbance, anxiety, muscle joint aches, right? Blurred vision, headaches, multiple chemical sensitivity. There are so many things here that are just not characteristic of allergy, just go far over what we see in allergy. And we just see, all the symptom profile. It's not just 1 or 2 symptoms. These patients are fairly globally sick. And that's what you see here on this big high level snapshot of mold symptoms in this study. But we can look at another group, right? So here's 105 patients, another case control study. 105 patients versus 200 healthy controls, without having mold exposure. And they're having profound neurologic symptoms. I go through this study in detail on another video, and I'll link that here. But just look at the numbers here, right? 75% have cerebellar dysfunction, right? 52% had peripheral neuropathy. You'll see that a lot. Ataxia, balance issues. You're seeing problems with fine motor control. You're seeing dysmetria. You're seeing tremors. These patients are profoundly sick. And I think it's really, really important that we're saying, okay, look, there's a big neurologic piece that really has to be looked at. There's also a psychiatric component, right? In that same study, it's just such a wonderful study. Just hats off to Ms. Kilborn here. It's just, I love this study so much. POMS is a well-established screening methodology used in the medical literature for depressive symptoms. Sorry, I didn't mean to scribble all over your POMS. I do love you. But what we're seeing here is you're basically seeing a 2 to 3-fold increase in mental health symptoms in patients who are being exposed to mold versus the controls, right? So here's the mold group, total score of 22 to 70. And then all of these roughly 2 to 3 times higher. Confusion, fatigue, anger, depression, tension. You're seeing all of these psychiatric symptoms, like that first man who said, weird anger and rage issues that he didn't have before. You'll see this quite a lot. And of course, all statistically significant. And so let's just review here. I hope by now, this very quick overview, you can clearly see that there is an allergic component that can make people sick, right? Well established in the literature, but equally well established, if you care to look, toxicity, right? These are not the symptoms of allergy, right? These are the things that patients are coming in, they're getting lost. They go to the rheumatologist, they go to the neurologist, they go see a half dozen different doctors, and they're still stuck. So what we really want to do is learn how to better identify these patients, how to diagnose them, how to get them right treatment. Here are some of the things in my clinic that I've found to be diagnostic clues for mold toxicity. And the first one, you'll see me repeat again, but when I hear I've got chronic fatigue and I have one or more neurocognitive or psychiatric symptom, my mind is going to mold, right? A very simple heuristic, and I keep that in mind. Chronic idiopathic urticaria, in my experience, is always mold. I'm sure there are other things that do it, but in Dr. Joe's world, this is mold. Mast cell, not every case of mast cell is caused by mold, but it's very common. All right, I would say mold is the most common cause of mast cell activation syndrome in my patients by far. And probably 30 to 40% of my patients with mold have MCAS. Dysautonomia in POTS, this is caused by mold more than any single other cause in my clinic. So please keep on the lookout. You really should just, as soon as you see dysautonomia in POTS, you should ask your patient, are you being exposed to mold? As simple as that. Anytime you hear a patient that's had a neuropsychiatric workup, they may be having mild cognitive impairment, and down the line they're diagnosed with an atypical neurodegenerative disease, right? It's kind of fits some of the criteria of Alzheimer's, but not quite. It's kind of Parkinson's-like, but not quite. Kind of atypical multiple sclerosis. That's mold, right? Just look for the mold, you'll find it. The patients that were, given the runaround in the chronic Lyme world, I was treated for Lyme, but I'm not better. They have mold. In my experience, chronic Lyme disease is mold. It's mold that was missed most of the time. In my experience, I don't specialize in Lyme or tick-borne illnesses, but in the cases I've seen, when there is Lyme, it responds really well to antibiotics and antimicrobials. And if you're just giving antibiotic after antibiotic after antibiotic and the patient is just not getting better, you got to think something else. And those patients, I think they have so many of those co-infections pop up positive because of the profound immune dysregulation that mold can cause, right? So I think mold is the cause of those positive tests more than the actual critters. I'll probably get flack on the comments, but that's how I see it. Mold can cause autoimmunity. We'll go through some papers later, but particularly new onset thyroid disorders, Hashimoto's and Graves. And I just highlighted chronic inflammatory demyelinating polyneuropathy. It is not a common autoimmune condition, but I've seen this in my clinic, and there is excellent clinical literature substantiating mold as the cause of this autoimmune illness. And then limbic dysregulation. Again, not the setting for a complete lecture on limbic dysregulation, but if you are familiar with limbic retraining, like the Gupta program, if your patient comes in and they've responded to limbic training, or they've seen a couple doctors and they said, I think you have limbic problems, they probably have mold. Okay. Chronic inflammatory response syndrome, CIRS, subtype water damage buildings. This is the main way that most doctors diagnose mold, in my experience. The patients who reach out to me, they've usually had workups and they've seen a Shoemaker trained physician. So Dr. Richie Shoemaker is really the brains behind this clinical characterization that we kind of shortcut as CIRS, C-I-R-S. And that dates back to 2006 when Dr. Shoemaker published a pilot study, and he described some inflammatory and hormonal abnormalities in 26 patients with chronic illness with mold exposure. And that was kind of the impetus. And since then, his students and proteges have published numerous papers regarding this diagnostic and treatment recommendation. And so, you know, credit where credit is due. Dr. Richie Shoemaker, I think, is absolutely brilliant for bringing this to the forefront. But I see problems with this, and we'll talk about that. But here are some of the references. I'll just pause it here, simply because, with humility, I never did any of the Shoemaker training. I've read a lot of the materials, and patients will bring me the labs from doctors who do the Shoemaker protocol and labs, and I don't think it works. I just don't see it work in my patients. And but I want, with humility, to say that it's well published in the clinical literature. Now, that comes with a big caveat, in that my understanding is that to become Shoemaker certified, you basically have to write a nice paper about Dr. Shoemaker, right? About how important the work is, or highlight some parameter of maybe the biomarkers that are important in your clinic. And so a lot of the literature is self-referencing, right? So you'll see Dr. Dooley kind of reference himself, and Dr. Shoemaker reference Dr. Dooley, and Dr. Dooley, reference the other docs. And that's a bit of a red flag. And we'll go through this a little bit, but this is how we make advances in medicine, right? We argue, we think, we read, we try different approaches in different patients. And we wouldn't be here helping patients with mold without Dr. Shoemaker and a lot of the brilliant doctors that he trained. So what the heck is it? Okay, it's complicated. All right. So CIRS, it's a dysregulation of the innate immune system resulting in a multi-symptom, multi-system illness. And this is quoted from the papers from Dr. Shoemaker and his students. And they always emphasize that it is not chronic fatigue syndrome. It is not myalgic encephalitis. It is a distinct clinical entity, and that chronic fatigue syndrome is often misdiagnosed. Instead, they feel it should be the CIRS diagnosis that's made. Okay. So the key here is that in this world, the Shoemaker doctors really define this biochemically. They say that there is this immune dysregulation, and you're going to see abnormalities in these kind of esoteric biomarkers, right? So you'll see a reduction in neuropeptides. You'll see abnormalities in inflammatory biomarkers, TGF-beta1, C4a, MMP9. Perhaps dysregulation of ACTH and cortisol, so getting into hormone dysregulation. Disruptions of vasopressin osmolality, abnormalities in gliadin antibodies, anti-cardiolipin antibodies into autoimmunity, and VEGF. And they say, look, analysis, you can use national laboratories to get these biomarkers, and many of them are trained to use something called visual contrast sensitivity testing. And they say, when you have a patient with CIRS, right, there are many things that could cause this clinical presentation. Chronic Lyme, Ciguatera, algae, right, exposure, cyanobacteria, algae blooms, mold, and other microbial growth that are associated with mold and with water damaged buildings. So in practice, all CIRS is mold. So if you go see a Shoemaker doctor, they're running these biomarkers, and they're kind of diagnosing patients with mold, Lyme to a lesser extent, but mostly it's kind of, if CIRS, then mold is what I'm seeing from the patients that come to see me. And after years of back and forth and study and publication, this is the definition of how you would define someone with mold illness based on Dr. Shoemaker's work. And so this came from a book, a clinical text that Dr. Shoemaker contributed a chapter to. And I quoted this as directly as I could. Apologies if there's a typo, but this was very hard to find, right? I couldn't copy the PDF. I had to type it manually, but I wanted to put it here because this is not clinically helpful, right? Here are, 4 things. We propose a definition of sick building syndrome include each of the following elements: potential for exposure with documented presence of toxigenic fungi, evident fungal growth, or a history of water intrusion, musty smells. and the presence of multiple symptoms in 4 of 8 symptom categories, absence of co-founders. 2, 3 of the 6 criteria, VCS, the visual contrast sensitivity, some of these CIRS biomarkers, MSH, MMP9, HLA genotype, ADH osmolality, ACTH cortisol dysregulation measured at the same time. We're already deep in the weeds, right? And then the final criteria, 2 of the 3. Response to cholestyramine, the bile acid sequestrant, with abatement of symptoms and resolution of VCF deficit to control levels. Verbatim, reduction of leptin if elevated with treatment, MMP9 if treatment, and also 4, be aware of markons in deep navel spaces, and elevated levels of myelin basic protein antibodies. This is a research proposal. It is not a clinical proposal. We can have a brilliant doctor who really is pushing forward a lot of good ideas, but have something that's a clinical disaster. I'm trained in family practice. I treat kids, I treat adults, and we have to be practical if we're going to help patients, and this doesn't help patients. This confuses doctors. This gets doctors focused on the wrong things. This gets patients focused on the wrong things. This gets people micromanaging very fickle biochemical abnormalities that's just lab noise. And it confuses and hurts more people. So I'm going to be honest. I used to be a lot nicer, but I just see too many patients who are hurt by this stuff to just not say anything. I think this is ridiculous. I had a very hard time finding reference ranges for the CIRS biomarkers. This is deep inside a study. And this is frankly the kind of gobbledygook that you'll see come into your office from a Shoemaker trained practitioner. You'll see reams of PDFs tracking these over time. You'll see what appears to be noise, but people following and bolding and highlighting, right? In this paper, the physicians were giving VIP intranasally, kind of an off-label, somewhat experimental approach to correcting these biomarkers. And then they were following the CIRS markers, and some went up and some went down, right? And it's all just kind of a mess. I think there may be a place in the research setting for this, and maybe 10 or 15 years from now, we would say, if we really focus in on, I don't know, MSH in this clinical population, at this point, we know that you're exposed to mold, and if this point you're likely to respond to this, but we are so far away from that right now that I think that we just need to move away from this overly complicated, finicky approach. So, of course, because this clinical approach is dominated by biomarkers, and these are the markers you can get at labs, the whole approach kind of devolves into obsessing on movements of these markers, and they're expensive, right? This is, I think, a nutritionist, Nutrition by Judy, sells Shoemaker lab packages with some sort of auto interpretation, and it's somewhere between $1,000 and $1,700. This is kind of what you'll see. I typically see when someone has come in and they've been through the Shoemaker approach, they usually kind of stick with it for a couple years. They're usually spending between $4,000 and $6,000 a year on these tests, because the idea is you're getting the tests and you're introducing cholestyramine and nose sprays, and you should be seeing drops in the biomarkers. But then if you're not, you need to double back and treat differently. So patients are spending a humongous amount of money. And this is money that needs to be spent on remediating their house. It's money that needs to be spent on practical treatments. And if you waste your patients' freaking money, you can't heal them. So if nothing else, if you do only just follow the symptoms of your patients and forget every single test, you'll do a better job than wasting your patients' time and money with this stuff. Let's talk a little bit about some of my problems with the markers. They're unreliable. It's just the only way to say it. These are unvalidated biomarkers that are measured, and they're different when you get them in different labs. They're not validated. There is a large amount of error between laboratories. They have short half-lives. They are prone to breaking down in the test tubes, right? They have to be drawn in a certain way. They have lab error. And there's no standard ranges, right? If you go to Dr. Shoemaker's website, there are their proposed lab markers, but we don't know if you are a male, is a TGF beta different than if you're female? If you are being exposed to mold, is the TGF beta different than if you are not being exposed to mold? At what point do you treat? These are things that we don't have answers to. The other big problem is, again, these CIRS panels can be a number of clinical problems that could cause these inflammatory markers to come up. It's not specific to mold, right? They say that in the definition. You get all these biomarkers and it could be Lyme or it could be mold. That doesn't help patients, right? Okay. They don't help guide treatment. They can't accurately diagnose mold specifically. And these markers don't consistently improve when patients improve. And I've just seen too many patients who've come in and they've seen labs go up and labs go down and they still feel the same. They don't correlate with symptoms. This type of finicky, lab-obsessed approach not only costs money, it makes patients neurotic. If you get this training, you are encouraging your patients to become anxious and obsessive and neurotic, and you don't want to deal with those patients, right? You want people that can get better, that want to get better, that aren't going to get sidetracked on silly TGF beta markers, right? You don't want to get into this if you're not in it. Okay, feel better. Thank you for letting me vent a little bit. We want to help patients, right? And I just feel so strongly that this approach doesn't help patients, and that's really where I'm coming from. I want patients to be better, and I see too many patients who've wasted so much time and so much money not getting better. It's not that there is no research validity to this. It's not that we shouldn't learn more about these things, but we can't use them to diagnose and treat mold anymore. Okay. Here's what I think we should do. This is how I approach it in my clinic. 4 pieces. 1, symptoms need to be correlated with exposure to mold, right? So symptoms should begin or worsen after exposure to a water-damaged or moldy building. Pretty straightforward. 2, there's a characteristic symptom that I see in all my mold toxic patients. I've been doing this for over a decade. I've seen several hundred of these patients, treated them over time, over many years, and fatigue. You have to have chronic fatigue. You have to have a unexplained neurologic or unexplained psychiatric symptom associated with a water damaged building. That's really it, right? Symptoms, you have to rule out other things. They can't be attributed to another illness, right? If your muscle twitches and muscle tics go away with magnesium, right? Okay, it's not magnesium. If your peripheral neuropathy goes away with B12, okay, that's not mold. If your chronic fatigue gets fixed with iron replacement or fixing your sleep apnea, okay, then that's not mold. But these symptoms, this pattern is just so characteristic of a chronic mold toxic patient that I just encourage you to remember that. So exposure, it's got to have exposure, right? You have to have the symptom profile, can't be something else. And then last but not least, I do think because we still have so much resistance in the medical world of mold diagnosis, and we still don't have a standard, universal agreed upon gold standard, the CIRS is not it, right? I think we should have biochemical evidence of mold. So in my clinic, that's what I do. And I don't think it matters. We'll talk about this next, what testing to get, what are some of the advantages or disadvantages, but I tend to rely on the testing that I found the most validation in the clinical literature. So that is IgG antibodies against mold, urinary mycotoxins, and then potentially I'm open to getting antibodies to mold toxins and mycotoxins to in serum. Can you find aflatoxin, just floating in your blood? I have some reservations about those, but I think we do need to prove that there is the abnormal immune reaction to mold. There's an abnormal amount of toxin excretion to mold. You need some biochemical evidence that mold is there. That's how I do it. 1, 2, 3, 4. Again, it doesn't have to be this hard, right? Okay, let's dive into some of the testing that I like to use for mold. Okay. Here's Dr. Vojdani and Thrasher in one of the best papers that you can find. What they did was they were looking at antibody levels in mold exposed patients versus controls, right? So case controls. And they got a whole bunch of different immunoglobulin measurements. And they specifically found an elevation in IgG antibody levels. And I think that they did find antibodies to mycotoxins as well, but they really did see a big influence in the IgG antibody levels. And I see that in my practice as well. I'll find that this is the more commonly elevated immunoglobulin when I'm getting blood work, and I find it reliable and helpful. And so here are some of the data that they show us, right? So first point, 10%, 15% of healthy controls have positive antibodies. This is true for many antibodies that we can measure, right? So we know that this is true for ANA, right? We know it's true for TPO. 10 to 20% of the population for those antibodies are perfectly healthy, no evidence of clinical disease, yet they have positive antibodies floating around. So just having antibodies alone, you cannot diagnose mold toxicity, right? That's why it is one of the 4 criteria that I suggest you use, right? But you are seeing, most of the controls, right? 10 to 15% are positive, and then just a much larger, bump, usually twice, sometimes 3 times elevation in antibodies in the mold exposed groups. And IgG, most consistent in my clinical practice, followed by maybe IgE. And we'll talk about that as we move forward a little bit. But IgG to mold species, and I will highlight Aspergillus, Penicillium, and Stachybotrys as the most common species that you will find mold antibodies to. Satratoxin and trichothecene, these are mycotoxins, right? So they did see an increase in mycotoxins here, antibodies to mycotoxins, and that's one of the reasons why I think we can consider using the antibodies to mycotoxins as a diagnostic criteria, but I still have some reservations. Okay, urinary mycotoxins. We have a really nice validation study that was done in 2019 from the then Great Plains Laboratory. Now it's Mosaic, and this was done by Matt Pratt-Hyatt. And what they did, again, case control, and they saw a large increase in the excretion of mycotoxins, right, in the mold exposed patients. Ochratoxin being by far and away the toxin that we were seeing the highest in the urine. Right. So again, you'll hear from actors, there's no validation for urinary mycotoxins. It has no place in diagnosis. They need to explain this paper. It's a case control study. Right? Just like the antibodies. I don't know. I didn't make it up. Everybody gets angry. Pulling apart the data, here's how I use this study in my practice. First thing we know, Great Plains, now Mosaic, they are a mass spec lab, and liquid chromatography. And what we have seen, those of us who've used urinary mycotoxins for years and years, is that again and again, this lab is very specific for ochratoxin and not very good at finding the others. And so I think that it is quite specific to diagnose mold, but I think it's going to have more false negatives than I'll show you from the real-time lab, which uses ELISA technology, right? So I think it's important that it may be more specific if we're using the right criteria, but it might give us more false negatives. And so we just want to be aware of that as we're trying to figure out what test might be better, right? So here, again, 51% of the controls had ochratoxin in their urine. The presence alone of a urinary mycotoxin in the urine is not diagnostic of mold toxicity. And this is the pitfall from the doctors who rely on the urinary mycotoxin test primarily. They say, oh, any tiny little bit of mycotoxin is mold toxicity. I don't think that that is accurate or helpful at all. I think that will falsely diagnose a lot of people who aren't sick from mold. But what we do see is, although 50% of the control group had ochratoxin, 85% of the mold exposed group had it. But look at the average numbers here, right? So the average ochratoxin, right? 18.7 in the mold exposed group versus 1.7, right? That's a world of difference. It's huge, huge difference. And the higher median levels as well, right? So 10.5 to 0.2. And in my clinic, therefore, whenever I see from the Great Plains, Mosaic Lab, whenever I see an ochratoxin over 10, I consider that a positive. I consider that kind of like a closed book. Mold toxicity is almost certainly at play because I think it's very well established, right? And you can see significant p-value. The other main urinary mycotoxin testing methodology is from the real-time labs, and they're using an ELISA methodology. And from my perspective, this test is more sensitive, right? It picks up more toxins. And part of the reason is, of course, mass spec, you're finding individual molecules with accuracy. ELISA, you're seeing more groups of molecules that are similar. So we know that there are a number of aflatoxin metabolites, as an example. And this testing methodology will kind of clump them all together, right? You may not differentiate between different aflatoxins, but you say, okay, there are aflatoxins here. So I consider this to be more sensitive. I generally find it to pick up more toxins than the Mosaic, but I think there's more false positives. And so then the question is, we don't want to diagnose every patient who comes in our clinic with mold toxicity. How do we differentiate? What I do is I add them all up, and I add up all the named mycotoxins found on the real-time lab test. And this is my edit here, by the way. I made this up. And I use kind of this 4.6 as a general mark, right? This is the 50th percentile, right? The average patient is going to be right here, add them up 4.6. This data came from a publicly shared information from someone from the real-time laboratory on 9,500 patients from their lab. So we don't know the age range. We don't know more males, more females. I would love, 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 love for these labs to be more forthcoming about their numbers. I think that would help us do such a better job. And if you're a clinician and you're interested in this area and you talk to your reps, please, please, please help me and bother their labs. They need to do a better job validating their data. You know, we see ochratoxin levels of X in this group of patients. We see it in this age group. We see this. We need more information, and they're not going to release it unless we push them. And so 4.6 is the median. So what I do, I don't want to diagnose patients with mold illness who don't have it. And so I kind of think of adding all the toxins and then getting a scale, right? If you add all the toxins and it's 5 or greater, it's a positive test in my mind, right? It's mold is likely to be causing symptoms. If you add them all together and the total is 10 or greater, I consider mold highly likely to be causing symptoms. And I go a step farther. I think that there is more than likely current exposure. And I feel very confident about that. I've seen enough patients. This is my clinical experience, not a published study I can go to. I've seen a ton of patients. When it's 10 or greater, just so many of them are like, oh yeah, there's that mold in the bedroom. Now, here's how I think we avoid falsely diagnosing patients. If it's between 3 and 5, it's kind of an equivocal, indeterminate result. I think mold is less likely to be causing someone's perhaps chronic fatigue syndromes symptoms, and I might want to consider other diagnoses. And if it's between 0 and 3, I really am skeptical. I just am not sure that mold is the thing in this patient. Here's what a real-time lab test looks like, right? So you'll see the named ochratoxins here at the top, and you'll see the value here, and then they'll tell you present, equivocal, or not present. And so here's an 85-year-old with Alzheimer's dementia. Her total was 30.8. She had 4 of 5 toxins present. And so that's kind of how I chart it, right? I say, okay, well, at this time we had 3 of 5 toxins and the total was 20. And here we have 4 of 5 and the total is 30. And that gives me just a general ballpark. Where are they compared to other patients? And I find that this really helps me differentiate between groups of patients more or less likely to be made sick by mold. And so we can say, look, 90% of samples, at least sent to real-time lab at this period of time, had a total less than 13. I think this patient has a mold illness, and I think she's currently living in mold. All right. This is fun. This was sent to me by a colleague and friend, and what he did was he took his urine, he divided it into 3 tubes, and he sent it to 2 different labs. So he sent 2 samples of the same urine to real-time labs to test what is the accuracy between samples, right? Is this lab going really high and then really low? It's not. That would be a pretty bad sign that the lab is accurate or not, right? And then he also wanted to compare, what did the real-time lab look like versus Mosaic, right? 2 different methodologies. And I told you that the Mosaic was really good at finding ochratoxin, but not so good at the other toxins. And this is exactly, what my buddy found. And so similarly, right, we do see positive ochratoxin here on real-time lab, but a different amount. And we do see a whole bunch of other mycotoxins. And the bold here is when it was considered positive by the lab, of course, right? The other thing is that there's good agreement between the 2 samples sent to the real-time lab, right? And that's what I've seen clinically. And this is one of the reasons why I tend to use real-time lab more than the Mosaic lab is I just feel that it's more consistent over time. There'll be times when I think the mass spec machine at Mosaic is just offline, and you'll have a patient who had positive and then it's 0. Like, what the hell, right? She didn't stop being exposed to mold. I've seen that a couple times, and I think that it's hard technology to keep working well. And so for this and other reasons, that's why I tend to rely on real-time lab. Okay, I already showed you that the satratoxin and the trichothecenes, that we can see an elevation in antibodies against those mold toxins in mold-exposed groups increased versus controls. So why is there a question mark? This is the My Mycolab report. And this is a patient who came into my clinic previously diagnosed with mold toxicity. This gal had been put on cholestyramine and I think other binders and given itraconazole for a period of time, just still wasn't well, right? Those treatments didn't help her. And this was the My Mycolab testing against the specific mold toxins. And so satratoxin was the one I found in the literature that there was good evidence against. And so evidence for, excuse me. And so I see this and I see an elevated IgG to satratoxin, and that makes me feel comfortable that this patient has a diagnosis of mold toxicity. But I'll be honest, I have a hard time with this laboratory because I had several conversations with Dr. Campbell, and he just wouldn't share any sort of validating information, right? That study I showed you earlier, he couldn't give to me, even though he contributed to it. He wouldn't give it to me. And it just left me with a bad feeling that the test, rather than what is the best practices for what antibodies we really want to go after, I just kind of felt like we're just throwing a whole bunch of toxins in there, measuring antibodies, and trust us. It was how it left me feeling. So I'm open to this because of the published data, but I don't think that this is better than the urinary mycotoxins. I don't think it's better than blood work, and it's expensive and hard to get, right? So to get this testing, you have to buy the kit from the lab or order the kit for your patient. Then they have to book a third-party lab. The standard labs don't draw this, and they have to go find another third party or get someone to come to their house to draw their blood. And that's an additional expense. And so, maybe if this were just available, you could just get satratoxin IgG, it would be golden, right? You get that at Quest or LabCorp, but you have to go through all this hassle and expense. And I'm not sure that this is the right solution. So quickly, let's just kind of take a step back. What are the tests available to us? And just some closing thoughts here. Urinary mycotoxins. What is the toxin excretion? If you're exposed to more toxins in your environment, if you have more toxins in your body, you'll see more toxins in the urine, provided you are detoxifying well. One of the pitfalls of urinary mycotoxins is it's an excretion test, right? So if you have better renal metabolism and better renal excretion of toxins, you'll see more toxins in the urine, right? And so I had a family of 5, and then there was dad and mom, and then 3 kids in descending order. And we had the lowest levels of toxins for the adult, and then the lower the family got, the higher the toxin levels were. So kids, you'll see really high levels of mycotoxins in the urine. It doesn't mean they're sicker, right? It means they're better at detoxifying and removing these harmful things from the body. So we don't want to get too worked up over super high levels when there can be this differentiating factor between what's the renal metabolism, how well are we metabolizing toxins. And then there's different methodologies, so not all tests are the same. I think we talked about that. Serum mycotoxins. So in the public health literature, there are metabolites of aflatoxin that have been used and measured to say what is the exposure to aflatoxin in African countries. And it's validated, like they've used it and reproduced high quality science in multiple studies. And so this should be a validated way to measure mycotoxins. And this would be great if we could go to the lab and just say, okay, is there toxins floating around in the blood? That's pretty easy. Doctors know how to interpret that, right? The only lab I know of is Armin Labs in Germany. And the few tests I've seen have all been negative. So I don't know if this is just not sensitive enough for clinical use. But I think that we want to watch out for this and pay attention. This might be a tool moving forward that's really helpful for our patients. I think we talked about antibodies to molds pretty well. I think we covered that. I use Quest. That's the lab, the national lab that I have an account with. I don't have an account with LabCorp, so I'll share what I order in my patients in a moment. I assume that you can get the same or very similar panels in LabCorp. I just don't know. Antibodies to mycotoxins. So I screwed this one up. So pretend I didn't write this. We are detecting the presence of IgG or IgE antibodies against mycotoxins, right? And my MycoLab is the provider that does this. They have a unique testing methodology. I wish that there were more public data available to say, is this useful or not? And then I'm just putting organic acids in there. This doesn't diagnose mold toxicity, but it diagnoses candida overgrowth with pretty high sensitivity and specificity. I use Mosaic Labs for this one. They've got an organic acid panel, specifically the MOAT, the microbial organic acid panel. OAT. I don't think you need the full OAT test. You can just get the microbial analytes, and you're looking for the diarabinitol. And when that's elevated, almost always patients have candida overgrowth in their GI tract. And probably 75% of my patients with mold toxicity have candida issues in their gut. So very common associated condition, not toxicity in and of itself. And you can't use organic acids to diagnose mold toxicity. Okay, here is what I do for testing right now. This is what I think is the simplest. I think it's the most financially responsible. It's the easiest for my patients to get. And I think it causes the least amount of anxiety. I think there's the most amount of clinical evidence supporting this. And what I do is I primarily use antibodies. And again, I get them through Quest. These are the test codes, right, in Quest. Again, it's going to be something different for LabCorp, but this is going to be the IgE, right? IgE. And then I'm getting IgG to really find, do we have a toxic, I'm sorry. Mold panel complete is the IgE, the Aspergillus. You know what? Take that back. I have found this one not to be helpful. I have since I made this slide, I have since taken the Aspergillus antibody screening off. It's extra money, and I wasn't finding it to be as accurate. So whenever I do a new test, I will compare it with what I know. And, for about, I think I have about 30 patients now where I had been using primarily urinary mycotoxin testing. And then for new patients, I would say for those who wanted to get a urinary mycotoxin testing and antibodies, I'd have them get both and I'd compare it. See, okay, did they seem to agree? Did they not agree? Is one high? Is one not high? And generally speaking, there is good agreement between elevations in IgG antibodies from Quest and the mycotoxin test, which I have the most experience interpreting and using. It's not perfect, right? But nothing's perfect in clinical medicine. So what I tend to do is I tend to get these four, 1, 2, 3, 4, plus or minus the urinary mycotoxin test. Everyone's different. It shouldn't be one size fits all, but I feel most comfortable if a patient is coming to me, they've been suffering for years, they're not sure what to do or how to go. I feel most comfortable having the antibodies and the mycotoxin test. It's giving me different information. IgE is the immune allergy component, really out of whack, right? That may need to be addressed. IgG, that's more likely to be a toxic mold syndrome. And then the mycotoxin test, what's their excretion like? What's their current exposure like? Do they not have really very much any when I would expect there to be a ton? Do they have just off the charts, mycotoxin levels like that Alzheimer's patient? I feel the best having these two, but I always present the upsides and downsides of these testings with my patients and let them choose. And so sometimes we'll do just the mycotoxin. Sometimes we'll do just the antibodies. And then some patients, we get nothing. I think that is absolutely an option. I think you have the option of going by symptoms. And for some patients, that is the ethical and moral thing to do. And so don't feel like you have to be bullied into getting testing, and use your medical judgment, right? And that will make happy doctors and patients. Okay. Mold testing should be used to establish a diagnosis. It's not used to track improvement. And this is true whether we're talking about getting TGF beta 1 and MSH, every 3 months. I also think it's if your doctor is checking a real-time lab mycotoxin test every 3 months. I don't find the mold tests helpful to track improvement. I think the test should be used to establish a diagnosis and then put aside. I will offer my patients just want to know. And so if every year they want to get a test, I think that's okay, right? That's perfectly fine. But what we don't want to do is say you have to get these to track improvement. That's, I think, really counterproductive for a lot of ways. For the biggest reason in that it's not accurate. I just don't find that when my patients improve that any of these tests consistently improve enough to justify the extra cost and hassle of ordering more tests on an ongoing basis. And again, functional medicine is expensive. Like, you got to pay for visit fees. You got to pay for supplements. You got to remediate your freaking house. We don't have unlimited funds just to throw at labs, right? Patients shouldn't be lab guinea pigs, right? They're here to fix symptoms. They're here to find why are they sick and then how do I get better? And too often in functional medicine, practitioners go nuts and they get obsessed about following all these biomarkers when they just lose sight of fix the freaking patient. Okay. So ongoing testing is just going to drive cost up, and I don't think it's needed. Again, the CIRS markers are not clinical reliability, or they're not reliable. And if you're using tests that we don't have a gold standard, we don't have 100%, perfect test in any of these mycotoxins, blood, antibodies, none of these are perfect. None of them are the gold standard. And if there is uncertainty, go with the thing that's easiest, right? Just go with the thing that they can go to Quest and get, right? Go to the single urine test in their house. Those things are fairly easy and fairly inexpensive compared to, $4,000 a year in CIRS markers. And I just would say, let's think one more time. The IgE, again, elevated IgE is going to say, okay, maybe there is a predominant allergy component rather than a toxicity component. I'm finding that those antibodies are really helping me say, where are we on this spectrum? Are we more allergy? Are we more toxic? Are they all high and the patient is just on fire? What do we need to prioritize first? And getting both the IgG and the IgE really helps me decide, which pathway I want to send a patient down. I wanted to, so this is like the closing thoughts, right? You could stop listening if you're bored. But I just hear from so many patients. I went to the doctor and they told me there's no evidence of mold. And yes, I've made a whole video, but I just want to click through a couple slides here and just highlight there is so much clinical and scientific evidence. on mold toxicity, on diagnosing mold toxicity, on these biomarkers, on what's validated and not. And there's so much BS out there. Here's the science. Okay. All right. We can find antibodies to mold and mycotoxins after exposure to water damaged buildings. Mycotoxins are associated with lots of different problems that I talked about. Mycotoxins are detected in the blood of individuals exposed to water damaged buildings. Urinary mycotoxins are validated in chronic fatigue syndrome. And I'll just keep the slides here, right? So you can take a look and pump in that PubMed to your browser. Urinary mycotoxins are associated with Alzheimer's and Parkinson's disease. Mycotoxins are detected in various bodily fluids. How you like that? Mycotoxins come from indoor environments, not food, just food, right? So we know if you eat, a barrel full of moldy corn, you're going to find mycotoxins in your urine. But it's not just the food, right? If you are eating a whole bunch of moldy beans and corn in Kenya, yes, we can say with confidence that your mycotoxins are probably coming from your food. But when you are in the United States, where we are not eating high volumes of moldy grains and foodstuffs, right? The mold is coming from indoor environments, and that's not just speculation, it's published literature. And then just for all the doctors who are saying that there is no validity in urinary mycotoxins, well, they can read the science. They won't, but they could. Okay, I truly hope that this was helpful to a lot of practitioners, maybe even patients. If you found this helpful, if you're still listening to me rant at the end of an hour, please share this. I wish that more doctors knew how much science there was. We've really advanced the field, right? It's not just, here is a $4,000 lab bill. All you can do is cholestyramine and nose sprays. We are so far past that we just need more doctors to pick up the slack, because we live in a world of global warming. Our homes are aging, and so more and more patients are at risk for developing mold toxicity, and there are so many patients out there who need help. So please share this with anyone you think would benefit from it, and thank you so much for listening.